small amounts of the food they're allergic to, and then over time we gradually increase those amounts until the patient is tolerating a good amount of the food. So today I want to discuss some common challenges that we have during oral immunotherapy and just practical solutions for those challenges. So I have no disclosures, but if I do have anybody who biased me towards OIT, it's these two guys. One of them is in the back right there and is going to talk later, Dr. Silvers. The other is my son. And so my son underwent treatment with Dr. Silvers about 8 years ago for OIT and made me a believer for sure. So today what I want to do is take you through a hypothetical patient who goes through OIT and experiences many challenges. And this kid actually, if you can kind of see him in the background, is one of our real OIT patients. His name is really Michael, but all the other details about him are made up because I needed him to experience lots of challenges so we could do this talk today. So Michael's a 6-year-old. He's got a history of immediate hives and vomiting upon peanut ingestion when he was about 2 years old. He's also been avoiding walnut, mostly because some allergist somewhere tested him for walnuts and he was positive. He's never actually eaten them before. And so the very first thing we need to do with our patients when we decide if we're going to go down this OIT road is figure out who's a good candidate for OIT. And honestly, that's half the battle with OIT, is figuring out who's allergic and what they're allergic to and what we need to treat. So the first thing we're going to do with Michael, just like we do with all of our patients, is take a really good history. Remember, your history is going to help you weed out food sensitivities versus food allergies. We can't treat food sensitivities. Food allergy is what can be treated with oral immunotherapy. You guys kind of know the difference between these two, so I'm not going to spend a lot of time on this slide talking about it, but just know that since Michael had a history of this almost immediate hives and vomiting after he ate a peanut, that is much more indicative of a possible food allergy than sensitivity. Remember, we see these sensitivity patients, a lot of times it's delayed reactions, lots of random like GI complaints like constipation and bloating. And those patients would not be eligible for OIT. So, does Michael have an allergy or a sensitivity? With his history, we're pretty sure he had an allergy at least when he was 2, but he's 6 now. So we need to figure out what's going on with him now. So the next thing we're going to do is get some testing, and we obtained both skin prick and allergen-specific IgE on these patients. When you get allergen-specific IgE, you want to make sure that you're running components when it's applicable. And so when would it be applicable? If you've got a patient with a milk or egg allergy who's never been introduced to baked milk or egg, that is milk or egg in baked goods, and you're not sure if they can tolerate it, you're definitely going to run casein if they have a milk allergy and ovomucoid if they have an egg allergy. Those are the components in milk and egg that are not destroyed when the milk or egg is heated. And so if they have a really high casein or ovomucoid level, that indicates to you that they probably cannot tolerate it in baked goods. Kids who can eat things in baked goods like this outgrow their allergies sooner than kids who can't. So if we've got somebody with a really high ovomucoid or casein level, that makes us lean more towards treating OIT even earlier in these kids because they're unlikely to outgrow at an early age. The other things that we can test components for are peanuts and tree nuts, and actually Sesame LabCorp is coming up with a test. Has anybody actually run the Sesame component from LabCorp? Savannah's done it. Okay, I haven't even run that yet, but it is available now. With peanuts and tree nuts, it can be really confusing. There are a ton of components, but the two to remember where an allergy might be milder than others are two that are indicative of oral allergy syndrome, and that's with peanut. If they're only positive to ARAH8, that is indicative that they might just get like some oral itch when they eat peanut, and that is not really severe enough for us to warrant having to do OIT with them. And then with hazelnut, if they're only positive to core A1, that would also indicate just oral allergy syndrome and also not severe enough to need OIT. Also, we want to consider like the natural history of food allergy. How likely are these kids to outgrow on their own? Because OIT is quite an undertaking. We don't want to commit somebody to years and years of daily dosing when they think they might outgrow an allergy really soon. So we need to think about which allergens are more likely to be outgrown. Things that are outgrown early in childhood are wheat, soy, milk, and egg. And then there's things that are less likely to be outgrown: sesame, peanut, tree nuts, fish, and shellfish. And so we're more likely to treat those latter things in younger kids and maybe hold off on wheat, soy milk, and egg, especially if those milk and egg components of casein and ovomucoid are negative when we can get those kids eating baked egg. Usually when kids tolerate baked egg, we don't treat them with OIT. This is a slide. You guys do have access to all the slides, so I'm not going to go over it, but it just talks more about the natural history of food allergy, who's likely to outgrow when, and it's a really helpful guide. So if you guys look under kind of the materials section on the app, you'll see my slides and it's in there. So we test Michael. Michael's skin prick test is largely positive to peanut, 13 millimeters. We run an IgE on him. It's greater than 100. So are we going to treat Michael with OIT? Or are we going to try to do a food challenge with him to see if he's still allergic? What do you guys think? Go ahead and treat him, right? Walnut. If walnut IgE, his skin prick test is 5 millimeters, his IgE is 4.2 Ku per L. You guys want to just go ahead and treat the walnut? We're already treating peanut, or do you want to challenge him? I agree. So we definitely don't want to treat something that's not an allergy. So we really need to figure out, and there are a ton of these kids out there, right, that have a peanut allergy. We know they reacted to peanut, and then somebody somewhere ran a whole bunch of testing on other allergens for them that they've never actually eaten. Or we've got these eczema babies out here who had testing on everything. They're avoiding everything, and we really need to figure out if they're allergic to something or not. And so whenever we have a distant reaction history or no reaction history and kind of low positive testing, we definitely want to bring them in for an oral food challenge. So the question of the day is, what constitutes low positive testing? We usually use 50% positive predictive values from IgE numbers. So if you look kind of in that box that is highlighted in teal, those are 50% positive predictive values for some of the allergens. If you'll notice, like wheat and soy, those numbers can be really high and still only have a 50% positive predictive value. So whereas I might challenge a patient who's got a wheat IgE of 18, if they had a peanut IgE of 18, I probably wouldn't. So remember that those numbers are all different. Unfortunately, this chart doesn't have tree nuts, so a spoiler alert for tree nuts, we usually use 5 Ku per L on tree nuts as our kind of challenge cutoff. Now, this does mean that 50% of the time your kid might fail the challenge, right, when you bring them in. So you need to be kind of prepared to deal with a reaction during a challenge. So we challenge Michael. He passes his walnut challenge. He wants to start OIT for peanut, but he's got asthma. He's well controlled, though. He's on a daily ICS. And his mom is a little bit worried. He's got asthma, he's got this really high IgE. Can he still do OIT? And so that's when we get into, are there any hard no's for OIT treatment? And the first one is uncontrolled asthma, right? This is just like your SCIT patients. You're not gonna start an uncontrolled asthmatic on SCIT. You're also not gonna start an uncontrolled OIT patient on SCIT. So you wanna optimize the asthma before starting, but in Michael's case, he's optimized. Also, history of ICU admission or intubation to a food allergy reaction. This is not your garden variety anaphylaxis, right? These people had to be hospitalized. They had to have a breathing tube down their throat. We're gonna be much more careful with these patients. Maybe have them do sublingual immunotherapy first, which Dr. Silvers is gonna talk about in a minute, and then maybe gradually bring them on to OIT. And then finally, this is kind of a relative contraindication. If they've got a history of eosinophilic esophagitis, we're gonna be very careful with these patients. We have treated a few. I've got one right now that's undergoing it, but he's in remission. He's also on dupilumab. So we definitely wanna make sure that they're in remission before we start EOE patients. So Michael can definitely do OIT even though he's got asthma because he's well controlled. What about that super high IgE? If I had a nickel for every patient that came to me and said, my last doctor told me that my IgE was too high to do OIT, I'd have a lot of nickels. Would you have a lot of nickels, Dr. Silvers? Yeah. So who does better during OIT? It's younger patients. And then also patients with lower allergen-specific IgE. So this is where these doctors are getting this from. You do fare better in OIT if your IgE is lower. However, we treat patients routinely who've got IgEs over 100. We just need to know they do have a slightly higher anaphylaxis risk. They also have a slightly higher risk of not being able to develop something called sustained unresponsiveness to their allergen. So they're more likely to have to dose daily for a long, long periods of time. So Michael starts OIT for peanut. How likely is he to have just a mild reaction to dosing, and what's his anaphylaxis risk? Mild reactions are really, really common during OIT. I tell my patients, just prepare yourself. You're gonna have some sort of mild reaction, oral itch, maybe tummy upset, etc. It's going to happen to you. This chart is a comparison of several different OIT studies and kind of the percentage of patients who develop some sort of reaction during OIT. See, it ranged from 51 to 94% of patients. So kids are gonna have some sort of mild reaction. But what about anaphylaxis? When you kind of look at all the different studies, anaphylaxis ranges from between 8 to 23% in the buildup phase for most of these studies. One thing that we discovered in our practice and actually presented at the college in November was that our patients who are treating more than one allergen at once have more than double the risk of anaphylaxis. So we do need to think about that when we are treating patients and kind of let them know that their anaphylaxis risk may be a little bit higher if they're treating more than one allergen. Also, just like Michael, higher baseline IgE, more of a risk for anaphylaxis. And then there are a couple of other things that increase adverse events as well. A history of allergic rhinitis and a history of asthma, which we know Michael has asthma. But Michael also has a pretty severe ragweed allergy. He lives in Texas. Can anybody guess what month he ends up needing to use his EpiPen? What do we hear? August, September, maybe October, right? During the peak of ragweed season. We've noticed this anecdotally for years on the Spruce app, which is the app we use to communicate with our patients. I actually, until I started this talk, was unaware that somebody had actually done a study on this and found there are for sure seasonal peaks in OIT reactions with kids who have allergic rhinitis. So you'll see there's a big peak there in the spring allergy season, April, May, and June, and then there's another big peak August, September, October. Just make sure that allergic rhinitis is pretty well controlled in these kids because it can be a risk factor for them to have reactions. So what are some other triggers or risk factors? And then what kind of prevention strategies do we use to mitigate this risk? You can see sort of a rundown of all the risk factors that may trigger allergic reactions in these kids and things that we tell them to do to help mitigate that risk. One biggie is exercise, and so we have all our patients not exercise for 2 hours after a dose, and that does continue into maintenance after they've graduated the program. They're still not going to exercise 2 hours after a dose. That's a major lifestyle consideration for people, so I like to have that up front with patients and make sure they know that going into OIT. Another thing that I've noticed a lot, lack of sleep. I tell my patients no good dosing happens after 9 p.m. And then occasionally we'll see reactions after NSAID ingestion. Alcohol we don't encounter too much because most of these people are underage. We do see though, some of the girls when they hit puberty, they do have reactions around the time of their menstruation and we need to be aware of that. So Michael kind of overcomes his little anaphylaxis episode. He continues to dose, but then he starts to develop nausea and vomiting about 12 hours after his dose. It's happened 5 of the last 10 nights. What's going on, y'all? EOE, yeah. So we're not gonna call it officially EOE because we're not gonna send Michael to GI usually and have him biopsied, and that's the only way we'd know if he has EOE. But the OIT literature has kind of coined this phrase of ELORS or ELORS, eosinophilic esophagitis like OIT related syndrome. It's characterized by this nausea and vomiting hours and hours after a dose. It's so long after the dose that sometimes the families do not think to tell you because they do not think it's related. And so sometimes you find this out after it's been going on for a couple of weeks. How do we diagnose it? We're gonna look at clinical signs and symptoms, and also we're gonna look for a rise in their peripheral eosinophils from baseline. So before any of these kids start, we're always gonna run a CBC with diff. That way we have their baseline eosinophil count. You guys know people with allergies have higher eosinophils than your average Joe anyways, so we wanna get their baseline. If we see that it's risen significantly from their baseline, that gives us an indication that they might be developing this ELORS, and then that lets us know we need to figure out how to make this stop. Remember, it's not EOE for sure because the only way we can really diagnose EOE is with an EGD and biopsy. In the vast majority of cases, we don't need to go there with these kids. So what can we do for Michael? There's basically 3 ways we can manage ELORs. The first is we can continue OIT. We just need to drop the dose to a tolerated level. A lot of times that's like 1/10 of the dose that they're currently taking. And they hang there for about 4 to 12 weeks until everything just smooths out and they're rocking and rolling with their doses. And then you're going to run a recheck of that CBC with diff, and a lot of times you will see that those eosinophils have indeed decreased. And if they have decreased closer back to their baseline, then those patients can start updosing again, but we usually make the updose interval longer. So if they were updosing weekly, we tell them that you need to updose every 2 weeks now, and you're a little bit more careful with these patients for sure. The second thing they can do is transition to sublingual immunotherapy. When they do transition to sublingual immunotherapy, we have them hold the drops under their tongue, but instead of swallowing them, we have them spit them out, so we bypass the esophagus. And then the third thing we can do is just stop treatment, right? The vast majority of these cases, about a week after stopping treatment, the symptoms go away. So Michael's diagnosed with this ELORs, he down doses, symptoms resolve, he slowly starts to updose again, but then he starts to hate the taste of peanut. So what do we do about that? So taste aversion is something that's really pretty well documented in the literature. It accounts for a lot of discontinuations. What's not well documented are solutions to that problem. Maybe we need to figure that out at some point. So most of these solutions that I'm going to give you are kind of anecdotal evidence of what we found helps in our patients. Trying to mask the taste helps. Think of savory items rather than sweet. So having a kid pour peanut powder in like ketchup and having him dip the ketchup in tater tots and eating it. It sounds really weird. Some people it works. Put a peanut on top of a Frito chip and eat it. These are all things people have done, and it does help the patients. Freezing can mask tastes, and bonus, it doesn't destroy the proteins. You guys remember chemistry, right? Heating destroys the proteins. Freezing just kind of slows those molecules down. So you can freeze the item. And then strong flavors like mint. So dosing with something like mint chocolate chip ice cream that is both freezing and mint tasting works for some kids. Other things like holding your nose, drying your mouth so you don't have as much saliva, or like drinking very cold water and chilling your mouth before you eat might help some of these kids. If masking taste doesn't work, try switching dosing forms. For peanut, we have a ton of options. There's not so many options for some of the other allergens, however. Whenever you do switch a dosing form, remember that we have made the protein calculations based off of just like a grocery store label, and so those grocery store labels are rounded, right, as far as the protein content, so the conversions between the types of food are not exactly correct. So please do it at a dose up if you're going to change dosing forms, because it might just be a little bit more protein than they're used to getting. And then the third thing we can do is adjust the goal. All of our protocols are written to bring kids to free eating that allergen. So if they hate it, they're never going to free eat it. So why are we going there? If we can get these kids to, for peanuts, say just like 1 peanut, which is about 300 milligrams of protein, that will protect them from the vast majority of accidental ingestions. You look at the bottom, there was a study about accidental ingestions and accidental amounts of protein in food. They found about up to 170 milligrams of protein of different allergens in food ingredients. And so if we can get them eating 300 milligrams, theoretically, that should protect them from most accidental ingestions. So Michael ends up graduating OIT. This is the real Michael with the real Dr. Silvers years ago. His family wants to know, though, does he still need to carry his EpiPen? And how long does he have to daily dose? These are huge questions that families have, because this is not like SCIT where we do a 5-year course and we're done. This is a long-term thing. These kids are going to have to keep this food in their diet for a very long time. So huge lifestyle considerations for these kids in maintenance. We talked about the no exercise period, which does remain in maintenance, and then also they are going to need to carry epinephrine in maintenance. If you take a look at this graph, this is various OIT studies. The blue bars are reactions, severe reactions during the buildup phase, and the red bars are severe reactions during the maintenance phase. So while they do decrease, they are definitely still happening in the maintenance phase, and kids need to carry epinephrine. So Michael needs to carry his EpiPen. Does he have to daily dose forever? So there's a lot of mixed evidence on reducing dosing days. Anecdotally, we do this all the time in practice, and we've had pretty good results. I think the difference between us and maybe these studies is we wait until kids are at least a year into maintenance before we start reducing dosing days, where these studies bring them straight to maintenance and then almost immediately start reducing dosing days. The longer you're in treatment, the longer you can go without dosing every day. So there was an egg OIT trial and a peanut open label trial that both tried to reduce dosing days. They both found that adverse events did increase in kids who were not dosing daily. The egg trial found, though, that the desensitization was maintained, so they could tolerate the same amount of egg whether they were dosing every day or every few days. Unfortunately, the peanut trial, they were only dosing with about 1 peanut. They did find that their threshold did decrease over time. So if you take a look at this chart, this was something that was presented at Quad AI this year. If you look at the brown bar, those are the kids that are dosing their 300 milligrams every day. And then we've got that black, green, and yellow bars. Those are kids who had sort of different ways of going down to dosing about 2 times a week. And the very left side of that chart is their ability to tolerate 300 milligrams, which is their maintenance dose. So if you can see, most of them could still tolerate their maintenance dose. That makes sense, that's what they're taking. But if you go all the way over to the right and you see their ability to tolerate 2,000 milligrams, that's about 8 peanuts. The kids who dose daily, definitely, most of them could still tolerate 8 peanuts, but it really decreased on the kids who were not dosing daily. They could not tolerate an amount over and above their maintenance dose. So the other option we have when we reduce their dosing days is to try for something called sustained unresponsiveness. So that's your ability to tolerate a dose after a period of avoidance. So the longer you're in maintenance, this makes sense, the higher your rate of sustained unresponsiveness is. There's also some data about who's more likely to pass a sustained unresponsiveness challenge, and it's the kids you would think of, right? The ones who have lower IgE, lower skin prick testing. Our epitope mapping friends, that's commercially available with Allergenis right now, presented at Quad AI that they can actually take a baseline epitope map of peanut kids and decide with an 81% accuracy who's going to be able to achieve sustained unresponsiveness. That's not available commercially yet. The actual mapping test is available commercially. We've ordered it on some patients, but this kind of prediction of whether they'll be able to tolerate sustained unresponsiveness or not is not available yet, but should be coming. And then I'm not going to go over this completely because I'm pretty sure I'm out of time, although I don't have a watch on right now. There's really no set universal parameters for reducing dosing days or trying for sustained unresponsiveness, but these are what we use in our practice as guides to decide if we're going to offer reduced dosing days or a sustained unresponsiveness trial to patients. The basic bottom line on this is we want them to be taking a full maintenance dose for a year or 2 years. We want them to not have any reactions, and we want a good reduction in their testing. For sustained unresponsiveness, they're going to avoid their allergen for 4 to 6 weeks, not dose at all, and then come back for a full oral food challenge for that food. If they pass it, then they can dose about 2 days a week. They can also consider dropping that exercise restriction if they trial exercise after dose at home and it goes okay. And also about a year into sustained unresponsiveness, they can finally consider dropping the EpiPen if they don't have any other allergens. So what happened to Michael? He's been in maintenance for 3 years. He doses 3 days a week. He still hates the taste of peanut, but he loves the freedom that OIT brings. So I hope you guys found this talk helpful and that it answered some of your questions about OIT and helped you know what to do when you encounter certain problems. If you have questions, you can email me there, and I think Dr. Silvers is going to talk in just a minute about SLIT.